Welcome, Professor Doyle.
Thank you.
You gave a terrific paper today at the Monieson Center's economics seminar, and I want to read you something. Actually, it's the first 2 lines of your paper and get you to respond to this because it just follows on what you were just saying. So what you said is a key component in the efforts to improve healthcare system delivery is the ability to measure hospital performance. It is often noted that if the payment system rewarded quality rather than volume, patient health could be improved at a lower cost. Why is that?
Well, so right now, if physicians perform more procedures in the U.S., they get paid more. And so that just sets up an incentive where if we're trying to decide, should we do this extra procedure? Why not? We're going to get paid more for it. A classic example is if someone has a heart attack and they do an angioplasty, or they're looking in the veins. If they blow up a balloon, the doctor gets another $800. So why not? Push the button, and then whether they needed the balloon or not, it doesn't really hurt the patient. They're already in there. Just push the button. But for the healthcare system in general, it could really lead to overspending if we're unnecessarily pushing buttons when we don't need to. So when I said that quality measurement is important, it's because one of the big hopes of what we call bending the cost curve in the U.S. So we're worried that costs are just growing exponentially. So we have to stop that, or that will stop because we just can't afford to keep going on that pace. How are we going to do it? Well, we don't trust the government to do it in the U.S. They're called death panels in the U.S., so we really just can't do that. And then we have insurers. We might think insurers would care how much it costs, but there was a backlash in the 90s when we let insurers try to ration care, so people don't like that. The last hope is that providers, hospitals, and physicians, if we gave them a global budget, say, someone comes in with a heart attack, and for the next 2 months, we're going to give a lump sum payment to the providers and say, you take care of that patient for the next 2 months of this lump sum payment that's not going to grow as fast as healthcare has, and let the doctors and hospitals figure out where to cut. There's some hope that the public in the U.S. would actually go for that. Now, the problem is if you start giving lump sum payments for all the care, you might get under provision of care. Because the a profit maximizing, if we were an economist, we'd say if they're maximizing profits, which we don't believe all hospitals are doing, but if that they would provide zero care if they just got the money, then why should they do anything now? So these bundled payments, they're called, are being tied to performance bonuses or performance penalties. So if you have low quality scores, like your readmission rate is very high, they're giving penalties now. So the hospitals are getting knocked with a penalty. Or if they have better than average scores, they can get a bonus. So you have to be able to measure that quality in order to combine that with this change in the payment system that we hope will be able to lower costs in a way that the public would actually accept.
So let me ask you about quality, because that's really at the center of your paper and your research in general. So it's very important in Canada these days because hospitals increasingly in each of the Canadian provinces are being required to hit quality measures for purposes of receiving funding. So quality is very important. So the question is, what exactly is quality? Now, in your paper, you differentiate between process quality measures and outcome quality measures. What are they and how do they differ?
Well, we can think about how do we achieve better health from a healthcare system? And one way to measure it is what inputs go into that healthcare system. So do they do the right thing? When you have a heart attack, you're supposed to get particular medicines that basically thin your blood and make you healthier. That's sort of what we call a home run technology. Every hospital should be doing that. Some hospitals weren't doing it at a high enough rate, so we now measure that and we basically have penalties for hospitals that don't do that. That's sort of an input based. Are they doing the right things?
Right.
And then outcome basis, we just measure whether their readmission rate or their mortality rate over time, it differs across hospitals. And a clear concern, especially among providers, is different hospitals treat different patients, and they're concerned that a hospital that treats, on average, sicker patients will be penalized in that kind of system versus a hospital that happens to have either wealthier patients or just healthier patients in general. So a big issue is how do you get an apples-to-apples comparison of patients across hospitals to evaluate whether one actually achieves better outcomes on its own rather than just happens to treat healthier patients.
Now, in your work, when you looked at outcomes, you had very specific outcomes, mortality rates. Why them?
Well, we find, economists, we talk about welfare relevant outcomes. So one of the things that we care about most would be mortality, because it's clear cut. We know that that's a bad thing. We don't like mortality. Readmissions, for example, maybe somebody needs to go back to the hospital to get treated. And if you had a very low readmission rate, it might be because you're underserving the area. You can't make the argument that, oh, we have too low of a mortality rate. It's very clean that we know that it's bad to have a high mortality rate.
Now, the paper that you delivered today is very, very rich. There's a lot to it. So just in overview, what are some of the things that you were looking for, and what did you find? And also explain the ambulance way of distributing patients. Very ingenious.
Okay, so just to restate, we're trying to measure hospital quality. How can we do that? And our concern, the big concern, is that patients differ across hospitals. So what we want to do is mimic a randomized trial. We'd like to be able to randomly assign some patients to one hospital versus another. And it's really hard to do that type of study. Maybe it's more appropriate for a patient to go to one versus the other. We're not going to flip a coin when we decide where to go to a hospital. So what we do is we use large-scale databases to try to find what approximates that. We call that a natural experiment. And our natural experiment in the paper I presented today is which ambulance company arrives when you call 911. We argue is that the ambulance company that's assigned to you is random, as good as random. Mm-hmm. And that's because usually the main ambulance company is busy. That's why you didn't get that one. You got the one that's called a mutual aid ambulance, one that has a contract to support when the main company is busy, we're going to come. Now that other ambulance company often comes from a hospital. And lo and behold, it's not that surprising that those types of ambulances typically take you back to their own hospital. So we have this random assignment mechanism of which ambulance company comes, and that, it turns out, affects which hospital you go to. So now we're effectively throwing the same types of patients, randomly assigning them to hospitals, and we find that if you score well on some quality measures that the government uses, it actually turns out when we look at randomly assigned patients that they do well. And other ones, it's not the case. So the one that we like the best, that performs the best mm-hmm. in this validation exercise, is the 1-year mortality rate of the hospital. So they have a risk-adjusted. In other words, you compare similar patients in terms of the age and other things that you can measure in the data. And the hospitals that do better in mortality rates on that measure, we validate that with this sort of ambulance natural experiment approach. I should say that it's controversial whether that score actually does measure quality, because the providers say, especially ones who score low on this, say, well, we just have sicker patients. Mm-hmm. And so we're saying that, at least for that measure, randomly assigning patients to those low quality or those that score low on that quality score actually do have higher mortality rates. Other measures we found didn't have that effect. So these process quality measures, like do they provide smoking cessation advice to pneumonia patients, we just find that even though that's a measure that the government uses, it's just not correlated with, it doesn't cause better outcomes when we do the validation exercise, which might not be surprising. A hospital that says don't smoke, that may not stop anyone from smoking, and it may be ineffectual.
Yeah. So something that's very important in all of this is developing public policy that generates change in hospitals. So I want to just give you another quote of something you said and ask you to respond to it. So you said, if patient outcomes are comparable across hospitals of a fixed quality level, and if quality levels are reliably estimated, then there is no reason to pay more to intensive, expensive hospitals.
Right, that's one hope for changing the way we pay for care. These sort of payment reforms and whether they can actually reduce costs but not affect quality. That's the goal. Yeah. So, or at least sometimes you could actually improve quality if you get it right. But the main goal is to just not have care suffer when you reduce the intensity. So a classic example would be an MRI, so a scan. Some are in hospitals and they charge thousands of dollars for the scan. Others are the same quality machine, but they're in an outpatient setting. And that say they're a tenth as much in terms of the price that they charge the insurer. Insurers these days are starting to say, we will pay for an MRI, but we will only pay what the high-quality, low-cost provider charges. And if you want to go out and get one at the hospital and pay $10,000 or $5,000 more, then you're free to pay it on your own, but we're not paying for it. And that moves patients. Patients don't pay that. They just go to the outpatient clinic, get their MRI, and that gets transmitted to the hospital.
I couldn't let an American economist go without asking for a comment on the Obamacare And so apart from the issues that have arisen in the last couple of days around implementation, just in terms of the public policy objectives, what's your overall assessment of that general approach? Good ambitions and objectives?
Absolutely.
Off the mark?
I believe so. What's getting lost in the current debate about the implementation is that the healthcare system was, I feel like, truly broken in the U.S. before. So, and this is not a right-left issue. It's just looking at the facts that if you get sick in the United States, you might lose your job because you can't do your job anymore. Then you lose your health insurance, and then that's just a horrible insurance system where if you actually need what you paid for it, that you don't get it anymore. It's like that's not what insurance is supposed to be about. So I think tying insurance to employer-provided insurance actually in general was probably a mistake we made back in World War II. But that's just entrenched, and we're not going to get rid of that. So now this healthcare reform that we've come up with builds upon what that is. And in Massachusetts, where I live, we have a lot of experience with exactly this. This was put by Governor Romney. It's exactly the same, as far as I can tell, the exact same plan that the Republicans don't like now was put in by a Republican governor. And the main issue is that there's some good parts and there are some costs to it. So taxes are going up to pay for it. There's an individual mandate that says that everyone has to have health insurance. Otherwise, if we're forcing insurance companies to accept all comers. Before they would charge a high price to someone who had a disease. Now they can't do that anymore. Then people could wait till they get sick to buy health insurance, which means that insurance would just unravel when it works. So having this insurance mandate makes sure that everybody's part of the pool, and that can make the insurance markets work better. And now it remains to be seen whether they can be implemented in a speedy time. But theoretically it should work. It's worked in Massachusetts to get more people insured. And when they get insurance, they don't just get access to health care, which is important. They also don't have the financial risk of if they do get sick, not only on themselves, but on the society and the healthcare system. So we were paying for a lot of care. Remember, I said 80% of the care, if you didn't have health insurance, is people who did have health insurance. But that was being borne by society one way or the other, whether it was taxpayers or other patients at the hospital. So we're going to pay for it one way or the other. This is one way to do it. With subsidies for people who have trouble affording it, and then if you ever look at the bill, it's about that thick in pages. So there's a lot that goes into that. There's about this much about the healthcare reform, and about this much trying to figure out how we can reduce costs in healthcare, including pilot studies that are trying to figure out how can we reduce costs and keep quality up. And that gets back to the original topic we started talking about.
Yeah. Well, a last question for you is that we in the Monieson Centre are clearly trying to promote healthcare economics and examinations, and that's why we're so very pleased to have you here. My sense is that the field is growing, that economists are becoming increasingly interested in healthcare, perhaps because it's such a dynamic field. Is that your sense as well? Is it a growing field, do you think, or is this just a blip? Or?
No, absolutely. I think it's definitely on the rise. You see that with hiring. So we're about to embark on our junior hiring, which is just an amazing marketplace, as you might expect as economists run a labor market. But you just see the number of postings that say we want a health economist, and more places are saying we need a health economist to study this crucial part of both public policy, and the outcomes are inherently important. This mortality, just you can't get around it. Like other studies, other areas you think about, like you said, jobs are important. I study child welfare as well. I think that's important. But healthcare has the main outcome is people's health, and people take that very seriously.
Well, Joe, you gave a wonderful paper today,
thank you
and
very
we're
much.
Delighted to have you here.
It was my
Thank
pleasure.
You. So we have been speaking with Dr. Joseph Doyle, Jr. of the Sloan School of Management at MIT, who has been visiting the Monieson Centre for Business Research in Healthcare at the Queen's School of Business.